Thank you, Fiona, for giving me the opportunity to talk about ACL injuries in teenagers. This is a topic that poses a lot of challenges to the patients themselves, to the families, but also to the clinicians who look after these young athletes who would like to return to sport. So I hope that by the end of this lecture, you will be able to suspect, if not diagnosed, an ACL rupture in someone's that you can watch on the pitch. I hope you'll have a better understanding about the increased frequency of this injury and what is causing, in fact, this increased epidemic and injuries. I also hope that you will be able to understand the treatment and the progress in the treatment that has been done in the last few years, and what are the challenges with this, consisting of re-injury, in fact. Most importantly, I think that it is important to know how to prevent those injuries and the psychological aspects that impact those athletes besides the somatic ones, which we are able to treat. So I'd like to present you a case, a patient of mine from 2021. This is Sarah, who's a 15-year-old transition year student who presented with an ACL rupture after playing a GAA match. She had surgery with me. We performed a primary ACL reconstruction with an extra-articular iliotibial band tenodesis. She had a whole year of rehabilitation. And after returning to playing GAA in the second match, she suffered an injury to the other knee. She returned then to us. We operated in the other knee, and this time it was a huge disappointment and for Sarah. And I had to ask for Dr. Jesse Barr, our psychologist, to work with her in the second year of rehabilitation consecutively. I had seen Sarah's parents recently because they came with her younger brother, who also ruptured his ACL while playing GAA. So this is a video of the injury that Sarah suffered. So you can watch her left knee, that is typical, forcefully step, trying to change direction, decelerate, and the left knee gave way. It's almost classical that the patients hug their knees, they go to the ground. It's sharp pain immediately. They often being helped off the pitch, but after a few minutes, although the knee gets quite swollen, it's not that painful. So this is a classical ACL injuries. So Sarah had surgery with us. Unfortunately, after returning after a year, she suffered another ACL injury. So how do we rupture the ACL? Well, generally, the vast majority of injuries happen with a non-contact injury. And as Sarah, as we saw in that video clip, the foot is stuck to the ground. There is an element of rotation to the knee, and the lateral side literally comes out of the joint for a fraction of a second and pops back in. And when that happens, the ACL, which is a small ligament inside the knee, gets snapped. A small minority of injuries happen through contact, when another player falls onto the patient's leg, or indeed from hit from the side contact, as we can see in this picture. Those injuries are generally more severe and are associated with other ligament injuries. This is a very interesting statistic that comes from our neighbors in UK, and the study concluded that for every ACL reconstruction surgery from 1990s, we are doing 29 ACL surgeries now. So there's a huge 300% increase in ACL injuries that we can see, possibly because it's way more awareness among the general population, also because at that time we didn't recognize those injuries and therefore we didn't treat them. I think everybody in the audience know a guy of my age who had a dodgy knee, who was strapping the knee while playing football. These guys generally tend to get arthritis in their 50s and 60s, requiring other forms of knee surgery. So just to expand on world-wide view, in US, due to their large number of sports people, there are about 100,000 towards 200,000 ACLs per year. It's an increase in adolescents and juvenile ACLs about 2.5% each year. And females are 4 to 6 times higher in cutting, pivoting sports in terms of ACL injuries. The Australia is the highest rate of ACL reconstruction in the world. When a study looked at under 25 years old, ACL rupture increased by 74% over the last 15 years. In Norway, they have a very strong ACL registry in Northern European countries, and similar increase by 40 and 55% respectively in males and women's in terms of ACLs in adolescents and juveniles. When we look at our own registry here at the Sports Surgery Clinic, which we started in 2015, I just took the last 5 years, and you could see at the bottom the grand total of ACL injuries in the under 20s has increased dramatically. In fact, in the last 3 years, we almost doubled the number of ACL injuries in young people. And why is this epidemic? As I said, it's a pure numbers game. Increased participation in younger age, who play for longer periods of time. They play a number of sports. They play throughout the year, winter and summer. As they get better, they tend to specialize in one sport, and that actually is shown to be a risk factor in itself. We also have increased awareness regarding the injury. So it's like everything else. When you have such injury, it seems like a new world opens up there with everybody around you having had the injury or knowing someone who had the injury themselves. Also, another factor is that we have more MRI availability, and that increases in early diagnosis. In the past, as I said, possibly people weren't diagnosed or just diagnosed with an MCL injury and therefore weren't treated accordingly. And there are some risk factors which are better recognized in more recent times. When I was training about 15 years ago in Australia, family history was suspected, but since then there have been various genes discovered as family history is a very significant risk factor for an ACL injury. And when I say family history, is brothers, sisters, parents. That also leads towards type of collagen, and that leads to hypermobility. So often those patients are double jointed, and if you ask around, they often have injured their shoulders before due to type of collagen and also hypermobility. As I mentioned before, the girls are more susceptible to the injury than the boys. And that is for a number of reasons. Firstly, girls will have a wider pelvis to accommodate childbirth, and therefore they have knock knees more often than boys. So when you have a knock knee, it's more likely that you twist, particularly if the hip muscles are not strong enough and the core muscles are not strong enough, and induce that rotation movement to the knee that snaps the ACL. There are also some hormonal variation that is suspected for increasing risk of ACL injury, increase of estrogen in girls sometimes, and the variation through the menstrual cycle has been observed. But other factors would be the anatomy of the knee. Some people have a narrow notch, which is the place where the ACL lives. And when you have a narrow notch, it's more likely that you rupture your ACL. Some people have increased slope, and these are all anatomical factors that really we cannot control, but it's important to be aware of them as treating clinicians. And of course, there are other factors, extrinsic factors, which we can control, and that is the type of sport. So we consider the riskiest sport, level 1 sport, in terms of twisting, pivoting, cutting sports, such as Gaelic football, hurling, soccer, rugby, and basketball or netball in other countries. Playing surface plays a role for ACL rupture. So it's been suspected, although it's difficult to prove, that the AstroTurf, due to increasing friction between the foot and the playing surface, that rotational force is being transferred to the knee where it ruptures the ACL. The footwear, through the same mechanism, if you don't have correct footwear for AstroTurf, and if you increase that friction even more, one can induce more rotation to the knee. It's been a myth that kids don't need to warm up. They definitely do. And I will show you some warm-ups that really are designed to prevent rupturing the ACL. And it's another myth that I want to dispel today, and that is kids don't need to go to the gym. They certainly do, and going to the gym is part of athletic skill development and athletic education. So in fact, the American Academy of Pediatrics has recommended that resistance training in children and adolescents, even prepubescent, is really useful on their development. And I don't mean going to the gym and doing CrossFit or lifting up weights, but weight resistance could be your own body weight. It could be elastic bands. It could be chin-ups, pull-ups, agility, proprioceptive exercises that should be done in the gym under supervision, and learning how to do correct jumps, hops, and step-ups. Now, when it happens, how do we fix it? We generally take a graft from a different part of the knee, and some techniques take a graft of the patella, when you take a piece of bone of the patella and a piece of bone on the tibia with a tendon in between, and the patella tendon is being rooted into the knee to become your ACL and being fixed with 2 screws. Another technique will be to take the hamstring tendons from the back of the leg, and similarly, that's being rooted in the knee to become the new ACL and to control rotation. So various surgeons have various preferences, but in this age group, when the physis and the growth plates in the kids are closing or still open, in particularly the prepubescent ones, hamstring is preferred due to the fact that putting a bone block through the physis is not really indicated. So what is the challenge with these injuries? Obviously, the same as primary ACLs happen more often. Also, the re-rupture rate is quite high. So when you think about it, why did it happen in the first place? Obviously, what we reconstruct, it's not as strong, as solid as what we were born with. And therefore, we encounter a re-rupture rate, a re-injury rate. And that has been reported around the world, irrespective of who does it, where it's being done, or what graft they use, between as little as 8% at 2 years, and as high as 30% at 3 years. So it's been widely accepted in the literature that in this age group, 1 in 4 athletes younger than 25 who return to sport after ACL surgery will go on to have a secondary ACL injury. And what I mean by secondary ACL injury is either re-rupture of the graft or injuring to the other knee. So if you think about it again, why did it happen in the first place? If you go back to the same risk factor, particularly level 1 sports, there is a huge chance that that will happen again, particularly to the other knee. And that led around the world for people to trying to reduce this re-injury rate and re-rupture rate. And on this background, the extra-articular procedure has been explored as an other surgical innovation in order to reduce the re-rupture rate. So what does it mean? As shown in the picture, beside doing the ACL graft, we also take a strip of the iliotibial band, which is a strong fibrous layer at the side of the knee on the outside, and wrap it around one of the ligaments to stop it rotating. I describe it as being like a seat belt. And that took vogue about 10 years ago. And the research that has been conducted since shows that the re-rupture rate has been reduced to less than 4%. So I would like to share with you our experience here in our practice in Sports Surgery Clinic. When we use the extra-articular procedure, I looked at all my patients over a period of 6 years. We had about 192 patients. We lost a few to follow up, but about 160 were followed up for minimum of 2 years. All these patients were operated with hamstring graft and extra-articular iliotibial band tenodesis, and they were followed up for at minimum 2 years. So this graph shows the distribution of females and males. There were more males in the younger adult group. There were a few prepubescent, about 10 patients between their puberty, before their puberty, and they require a special surgical technique. And the sports that they were doing, I grouped the GAA being hurling and Gaelic football. The vast majority, about 75%, were in GAA. A few patients played soccer, a few played rugby, and the rest played basketball or gymnastics. So what did we find after following these people from between 2 and 8 years? We phoned everybody and we asked them if they had any other surgery. So what we found is that the re-rupture rate, in other words, injury to the same knee, only 4 suffered this, and they were representing about 2.5%, significantly lower to the rates that I presented worldwide. And a significant number, about 20 patients, suffer an injury like Sarah to the other knee. Those represented about 12.6%. So what have we learned by looking at our work and data in the last 8 years? So we demonstrated that the hamstring graft and with the extra-articular iliotibial band tenodesis reduces significantly the re-rupture rate to 2.5%. There is still a high rate of contralateral injuries, about 13%. I insist that the patients will have a minimum 9 months of rehabilitation and to return to sport at 1 year after their surgery. We do that after we test them clinically and in our 3D biomechanical lab. And I stress to everybody at 9 months when I see them the importance of injury prevention. And we look at psychological readiness after such traumatic event and after such a long period of rehabilitation, if they're ready to return to sport. If you remember nothing from my talk, maybe you will remember this GAA 15 warm-up, which is excellent work done by our GAA community of physio and coaches. Essentially what this is an activate program. It's a warm-up that is about 15-20 minutes and includes a series of shuttle runs, strengthening agility and proprioceptive exercises. There are similar programs around the world, such as the FIFA 11 Plus or PEP program in the States. And there's been a lot of research done in collegiate athletes showing that if we do these warm-ups at least 3 times per week, we reduce the knee injuries by 40 to 60%. This is really important. If we invest time in becoming agile, strong, reactive as players, and our kids follow this warm-up, it's like brushing your teeth. You halve the re-injury rate. In terms of performance psychology, I was fortunate to meet Jesse about 2 years ago, and in Aspire Orthopedics, our office, along with Professor Brian Devitt and Mr. Gavin McHugh, we work in close relationship with Jesse, and she sees all our patients that require psychology intervention. Jesse is a former athlete and understands very well the trauma that those kids go through and helps them psychologically to get over the injury, to plan their rehabilitation, to plan their return to sport, and also to deal with a possible re-injury as well. So Jessie has been a great addition to our team, and I look forward to hear her talk. If you have any questions, I'll be delighted to talk to you in a few minutes after Jessie's talk. Thank you for your attention.